Tissue.
Sleeve all around.
Yeah.
Around this screw, do you put any sleeve?
No, no, not drilling before bone. I drilling on the and only hands free. No drilling.
He's not asking for the drilling. He's asking, will you put any cover on this to save the soft tissue? Sleeve.
Sleeve. Yeah, yeah,
That
yeah.
is what he's asking.
What he's saying is since he's not using any machine, there is no fast turning over.
Yeah.
The problem of soft tissue in the position is not that.
But it will be there. But it will be there without sleep.
No problem.
But so you put without sleeve.
There is no muscle sleep.
I put this.
In general, जो है.
Yeah.
Actually speaking, there is no
And
need to go out to the
yeah.
anterior cortex.
It usually
We
I.
are seeing it
Yeah. It usually I.
Image को देखना पड़ेगा without
It usually I testing. Fixation. Yeah. Another procedure on another side. Your choice. No. Again, you putting feeling on this point. Yeah. Yeah. Give the hammer.
इसका जो ये
जंक्शन है
ये जो जंक्शन है ये जंक्शन है
at the base of the transfer.
In lumbar, it's
same is it is the same
Yeah.
spot as the
No,
pedicle
no.
screw we are putting.
no. Feeling the process transversus up to lateral facet. In this point, yeah.
It's a right point.
It's not very dangerous.
नहीं नहीं ये थोड़ा सा
It is
Lateral malposition. It's very dangerous. Medial malposition of screw.
medial is also dangerous.
Yeah, very dangerous.
रखा तो इसने उसी पॉइंट पे ये पेडिकल और वो जो है मिलता है जहाँ पे
In
ट्रांसवर्स प्रोसेस
lumbar vertebra, biggest arch, biggest arch of vertebra. Not very dangerous.
It is at this place, I think. Inside,
yeah.
inside. Yeah. Here.
It's-
It is a right place is here.
How I see it's in anterior approach. I introduce in this point. I osteotomies by lateral facet and through the lateral facet drilling to screw.
Otherwise,
Okay.
in general, you pass here.
It's more medial.
from here or here
It's not very dangerous lateral malposition. Very dangerous medial malposition. Very dangerous. Yeah. It's
ट्रांसफर प्रोसेस में कहाँ
Good, good. सही है.
how you remember it's closed procedure.
इसने जो
It's
रखा
closed procedure. It's not open procedure. Yeah.
This one is not right.
so
And
It is pedicle. Yeah, if you
अच्छा इसको जरा
हाँ, pedicle का है.
इसी को
My-
रखो just keep it please
My colleague knows that if you use technique of closed procedure, it should be reading
on the safe line
on the safe on the anterior approach, anterior open approach.
It is little lateral to the conventional side at which we are putting our in the open.
Yeah.
You want to say this? It is little lateral.
It is away from this side because this is normal side is this.
It's this normal.
It is not.
It is the base of the transfer process, you mean?
Yeah.
इस पे तो टूट जाएगा
The-
फ्रैक्चर हो जाएगा कितना बड़ा
Just little.
जंक्शन
इतना
It is
इतना स्क्रू मीडियल
yeah.
मीडियल टू द बेस ऑफ द ट्रांसवर्स प्रोसेस इतना मोटा इसको डालोगे
It's the
inferior border of transfer
the area. Colleague, the area of putting of transpedicular screw in lumbar spine is very variable. Yeah. No, very dangerous if you making no transpedicular, transpedicle. You nose used
Transverse process.
yeah, processors, and this position, this area without radicular, without vasculation, it's not dangerous. But if you use this technique, we make
Damage the cord.
through damage. Yeah.
If you see lateral, this is the thickest portion. Chancery should come in this portion.
Yeah, yeah.
यहाँ से कैसे बॉडी में जाएगा ये बॉडी में जा रही है
The
इंटरपेडिकल
the height of arch more or less 1 centimeter. It's,
Inferior border of facet.
okay, and this
इंफीरियर बॉर्डर ऑफ फैसेट
feel on this
Or like a round lateral.
न्यूरोसर्जनिक
point.
In this it is very lateral, in this it is very medial.
Uh,
Just below the
it's normal. It's normal variable. It's a typical point of this.
Sinus है क्या?
Typical point of this, but this not it's plastic bone. It's not. It's very difficult to introduce.
Sir, can you draw the diagram and how we see in the Siam? Siam how इसमें तो दिखेगा नहीं डॉक्टर साहब, बांध थोड़ा दिखेगा हमें, कहाँ तो एक्सरे में तो हमें ये दिख रही है पेडिकल, तो पेडिकल जो दिख रही है हमें इस तरफ जाना है, इस तरफ जाना है या इधर जाना है. We would see it on the Siam. The pedicle. This is the eye of the.
Okay. The point of thoracic
Spine.
spine. It's more upper.
More upper.
Yeah.
Very good. Thank
It's,
you.
but с каждым нижним сегментом.
So when you're going lower and
Lower
lower,
down.
Well, low, it's more low.
Lower.
Yeah.
Thank you. Thank you.
And angulation, it's very different. In upper thorax, in this angulation, no more lateral angulation, but sagittal.
एक्चुअली एंगुलेशन डिफरेंस एट
More, yeah.
Yes.
नंबर 40 और नीचे 40.
That is what he says.
We don't remember sagittal kyphosis.
Yes.
Normal sagittal kyphosis of thoracic spine.
Okay.
But in lumbar,
Yes.
we see
Kyphosis of lumbar.
lordosis.
Lordosis, yes.
The point of introduce screw, it's more less.
Inclination inferiorly in the upper lumbar spine and superiorly in the lower lumbar spine. That is
Yeah.
what you want to say.
And
एंगल इज इंक्रीजिंग इन द वो पेडिकल
Yes.
वाला सिस्टम है.
ऐसे ही है ना.
उसमें
तो
नीचे
ऐसे
जो है
करना
40
है और
डिग्री और
ऐसे
ये
करना
वो
है.
ऊपर 20
Yes.
ऊपर 25 जो है जा रहा है.
we always used X-ray control.
हाँ, एक्सरे तो वही तो मैं
Yeah.
That's why we are
Yeah.
saying na
Yeah.
CR under CR we
So
will
that
do.
is finished. Proceed, sir.
So
Yes, let him finish.
this point,
under CR
yeah.
हाँ नहीं
Hammer,
CR के
fixate the nails.
वाला कहीं इधर उधर चला जाए.
X-ray control into plane.
So you
Yeah.
you
Don't remove this device.
double Siams.
we don't have two direction arms, so we have only one direction,
No,
one
double
plane
Siams.
Okay.
So we made
We make incision of bone. And this around you feel into the screw putting.
Tapping.
Yeah. Okay.
But
Remove
self tapping.
all device.
All device.
Yeah.
Self tapping.
Introduce and feel this around.
Drill नहीं करते बिल्कुल भी drill use नहीं करते.
The drilling, the drilling of bones, it's more simple.
ड्रिलिंग भी करते टैप भी करते को टैप ना लगाते हो तो ये
Okay.
जाता ही ना उसके करते हैं उसका ड्रिलिंग बिना उसके
हाथ से करते हैं.
Only hands free introduce only, not not power drain. Yeah,
कोई power release
yeah.
मत करो ये कर रहे हैं नहीं करो
We cannot field
जो कहीं भी shift हो जाएगी
the ball.
ये कह रहे हैं वो हाँ नहीं करना चाहिए वो
Yeah.
गुड
Okay. More.
हो सकती है प्रॉब्लम से डरो मत प्रॉब्लम से पहले डर जाओ
Okay. X-ray control.
हाँ स्पाइनल कॉर्ड को भी
X-ray control.
जितना मर्जी चेक कर लो ये हाथ से
That's enough. Yeah. Okay. Okay.
पूरा बिल्कुल और स्लीप ना यूज कर
We use the
मोर पिन
fixate on one segment. Test of fixator. The
हाउ मेनी पिंस यू आर पुटिंग
it's yeah. And this point.
पुटिंग द पेडिकल
Oh no. We
always on the lower edge.
and this.
के भाई
It's
the fracture and 4 down the fracture.
this point. Okay.
If it is scoliosis, it can be channel. Well, depends.
Sir, in a spinal fracture, the patient feels so much severe pain. So will he allow in local anesthesia?
Okay. Introducer.
वी आर गिविंग द एनेस्थीसिया
IV narcotic drugs.
Oh.
Only narcosis. We use only narcosis, not
Point
local
to
anesthesia.
Like
Three triangular.
Intubation.
We put in two base.
Intubation.
Looks like spondylolisthesis. Yeah.
Sir, patient is in full anesthesia.
And then this. Yeah.
Dr. Rajat, make it clear. Local or
No.
spinal?
No.
Use this plate and this plate.
Okay.
two plates only
Okay. This.
Gas anesthesia.
safer
It's very comfortable putting on this screw. It's the same plane of the upper screw. Yeah. Before comfortable connection.
नहीं तो ये जो स्क्रू सेंज स्क्रू डाला है ये
Okay.
पेडिकल की साइड में जा रहा है
What?
या इधर की तरफ
That's good. Lateral mass. Okay. Repeat in another side.
बात हो
this one or this one
Yeah. This transpedicular in S1, it's another plane.
okay
Yeah, it's more comfortable in this point.
this is the right plane
Yeah. We,
45
we see on this screw. It's the same plane of axial plane. Okay.
बहुत गिनना पड़ना चलो ये तो बड़ा ही
No problem.
हिंदी
Okay, that's enough.
where it is
Hmm.
it's all right
Okay.
it should come out
By cortical,
1 millimeter.
one plane. Good position of screw.
What is handy in external fixation that if
We use this. No?
you go
these
to
are
the
the pins
Oh,
to get out.
Take the wrenches.
okay. If we use distraction, it's more.
you are doing it in the neurological involvement also or it is only the where
If
patient is
we have distraction, it's more comfortable this position.
inside
Yeah.
if it is
If it is compression, this side. Yeah.
neurological
Yeah.
so you are going to distract
We distracted.
okay
Okay. Distracted is this.
एक मिनट
No. Ah, yeah. Yeah. Okay.
Fractures.
So in what type of
Sorry,
spine you are using it?
it's this more. Yeah, yeah.
Only in huge difference.
Tuberculosis we can use,
Very well. Many indications.
Okay.
Is that right?
but
How we
we
will
need
reduce
Good.
like how
Yeah.
we will reduce
We
We'll have 4 is to here, 4 is to here. Then we'll pull the bone.
okay. One.
how it will be reduced the spondylosis how it will be corrected.
Yeah.
Please show us, sir. In this model of spondylosis.
Okay.
उसमें फिल्म में देखना और इसमें अलग अंतर है स्लाइड जैसे
We put tube base for correction of deformity.
आपने ये क्वेश्चन तो पूछा नहीं मरीज लेटेगा कैसे?
प्रोन प्रोन
नहीं
Okay.
बाद में
स्पेशल गद्दा
Okay.
बनाएंगे।
दो गद्दा
Okay.
हाँ, गद्दे काट के बीच में लेट जाएगा।
Can be used.
पहले जोड़ो,
We can be used.
8 इंच का बनाओ,
Distraction,
बीच में
8
काट
इंच
लो
का
Distraction.
बनाओ, फिर इसको काटो।
compression,
अच्छा
rotation, and maybe reclination, maybe
बैकवर्ड
for
स्पॉन्डिलोलिसिस
spondylolisthesis, reduction,
यस
reduction. Yeah. If for reduction you must
यू हैव
more points and based on this position.
Yes.
After this, we
Here is another rod,
ओके
and
Yeah.
it will be more deep. Yes, because
yeah
and then you will with this rod like use it like jack.
ओके
Yes.
Pull the proximal
Go
fragment
yes
upwards.
to this plate with the rod. Yeah. To make like use like jack.
эта планка как ну как мост, как он, господи,
Like a yes, it's like a
like
plate
a
bridge.
like a
and-
bridge.
And here will be additional rod. Yes. And you can use it like a jack to get out.
नहीं इस पे कैसे यानी
How you will fix this plate on this? हाँ
Sir, please show us.
हाँ sure, sure. देखो 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 देखो
दिखाएगा
देखो सब लोग यार।
इसमें तो डिस्ट्रैक्टर लगाने के पहले ना इसको लगाना होगा जैक एक साइड का
एक प्लेट नीचे एक प्लेट
Okay. It's
मत होने तो देखने को तो है।
सर इसमें
it's
शायद जो स्क्रू जो है सर उसमें नहीं है कुछ
general info for
दिख रहा है
for impression, but in English
Otherwise it doesn't require plate.
we will be found of illizarov13 on English version.
यस
इसी के लिए ये
Okay, okay, very strong fixation. Move it on this segment is absent,
rotation is
and this segment no.
So this fixation is as strong as pedicular screw or more strong than pedicular screw?
Yeah, we fixate all column of vertebral, all
it is
anterior, medial, and posterior.
it is stronger
Whether
than
this is
pedicular
stronger
screw
or
if you
lesser?
compare with this pedicular screw.
Yeah,
Simple
yeah,
screw or this is strong and that pedicular screw.
yeah, yeah,
Which
yeah.
is strong?
is stronger than the pedicle.
Pedicular screw or these screws are strong?
So you mean their strengths of
Yes, yes. Simple pedicular screw.
Of course, pedicle screws, which are used in internal fixation, are more strong,
Okay.
more strong. And we have some problems with the fracture of these screws in a bad conditions. But now, when we use this system for a very short period of time, with quick change for internal fixation, we have no problem. This problem was usually when we used them for a big period of time, for example, when treating some fractures. But now we don't use it in injuries, no in fractures. Now we don't have this problem now. Very rarely.
How
So
you will
after
fix this?
removal of the system, when we do internal fixation, doesn't it get loose because of the pre-existing holes?
Yeah, you usually have some problems with the position of screws
I don't.
in internal fixation.
How to this?
I don't see a device for fixation these
इसको कैसे करोगे?
planks.
सर कर दीजिए ना करके
इस होल को
Okay,
थोड़ा सा फैल जाइए
your exit.
We really don't have enough details to do this. So, really, guys, you can do this. So we need more hardware. Yeah.
It's a very complicated thing when you come to us. Okay. And have the instrument they are available.
अच्छा मेल फीमेल हिंज से करेंगे क्या? हिंज से? It is fixed with the hinge only, not okay. It is not available. Fixed with male and female hinge.
Okay.
Then
It's fixed.
okay then.
Then we have a rod here. On the female rod.
प्लीज टू अस
I showed you in my presentation this system. Yeah.
On the female rod.
ऐसे नहीं कर पाएंगे.
I can show you easily.
You can show. Yeah.
I can show you
Yeah.
easily. Sorry. Can I use? I'll show you the principle. Yeah? So you can use different details, but if we don't have,
हम लोग जानना चाहेंगे और सबसे बड़ा इंडिकेशन ये है कि रिडक्शन गेटिंग रिडक्शन इज वेरी डिफिकल्ट अगर स्पॉन्डिलोलिस्थेसिस का रिडक्शन कर लेते हैं तो इससे बढ़िया बेस्ट इंडिकेशन हो सकता है यस सर वी शो दैट सर बट वी वांट टू नो हाउ टू अप्लाई दिस
you can use other. If you don't have anything.
some चीज हो
And if you want to use like a jack,
Yes.
you can go this way and it will be jacking up. Yes, up. The signal you want. So very simple, very simple really.
It has to be fixed to this.
Yeah, but not with the.
Not with the load.
We call
This we have to disconnect. Okay. These rods we have to
Temporary
These
fixation.
rods has to be disconnected.
Of course, this one here.
Alexander Vladimirovич, one cane point. One cane point. One cane point. We usually fixate on two. Yeah, it's more stronger because the power of very severe, very huge.
है हमको समझ नहीं रहे हैं ऐसा बता
Okay.
पोस्ट एकदम फिक्स
Have you one
वो स्पिनर तो होगा कहाँ गया? स्पिनर ले आओ.
supreme? Okay.
उधर से लाएगा उधर से.
एक नीचे लगाइए सर स्पैनर
मेरे हाथ से नहीं घूमेगा नहीं.
And one more rod. You have? Okay, good. Okay, and one more rod. You put. Just a moment. Okay.
रॉड एक और ले लेना.
आप डिस्ट्रैक्ट करो.
This long is
पहले डिस्ट्रैक्ट करेंगे सब.
good.
Is that good?
I don't see. This. It's the same long.
Same.
Okay. Okay. Okay.
इसका रेंज भी स्पेशल होना चाहिए.
That's enough. Okay. Yeah. Around.
हाँ अभी अभी पहले
This.
फिक्स हो जाए ये
Yeah.
फिक्स हो जाए तभी तो
Yeah.
करेंगे.
Yeah.
उठा
Yeah.
लेंगे इधर से अगर जाम करना है तो इसको जाम करने के लिए इसको उठा लेते हैं.
कर दीजिए ना बस.
वही तो सर हो गया.
You fixate this position.
इसको हटा देना है इसको दिस
ये
डिस्टेंस.
हट जाएगा ना, उसको टाइट करने के लिए रेंच.
Yeah.
अब कैसे होगा?
ठीक है.
If we put on the base on this vertebra, we want reduction on this
सर पुल तो कोई
base.
रेंज से ही होगा ना सर, कोई स्पैनर से होगा.
नीचे से इसको लूज करेंगे, स्पैनर होता है.
वो कहाँ है?
Sir, if you want to pull this plate,
तो इसको फिक्स कर देंगे, इसको करेंगे ऊपर. You will fix it, then
Yeah.
नहीं हम लोग तो
do screwing like this, it will come up.
इसका एक्चुअली अलग से स्पैनर होता है.
Down enough to get up. Down enough to get up. So sorry, I can't get closer. So for screen. So if you will use this tab, you
then
can
how
go.
to pull sir, how to pull and reduce, how?
सही कह रहे हैं सर.
When you are turning this knob, it is going up. So you can do this. Yeah.
ये अंदर का नट लूज करो, बाहर
The
का करो तो वो
middle base. The middle base. Put on this point.
This one will be going. Yes, this
Yeah.
one will be going down and up, working like jack.
Cover removes.
Tibial pseudarthrosis was first described by Hadgoher. Epidemiology of congenital pseudarthrosis is presented on the slide. Distributions of patients with congenital pseudarthrosis by sex and localization you can see here. The most common cause of congenital pseudarthrosis is neurofibromatosis type 1. Etiology of development, embryonic maldevelopment, congenital tumor-like lesion, congenital anomaly of nutrient artery, neurofibromatosis, fibrosis dysplasia, myelodysplasia. Clinical signs age, pigment stains, neurofibromas, physical and mental deficiency. The most well-known classification are Boyd's, Anderson's, Crawford's, Pozdeyev's, Paley's classification. Russian scientist Pozdeyev highlights neurofibromatosis of the first type, myelodysplasia and fibrosis dysplasia. Common Crawford's classification included 4 types. Boyd's classification is less popular. It contains 6 types. Dr. Paley highlights neurofibromatosis, fibrosis. Provides sure prognosis of the outcome and treatment strategy. Clinical forms of pseudarthrosis are latent and formed congenital false joint. You can see latent forms of congenital pseudarthrosis. Distributions of pseudarthrosis formation by age groups is presented on the slide. The greatest problems occurred in treating patients under 2 years. Factors prognosticating negative outcome are tibial dysplasia remains, pathological fracture with formation of pseudarthrosis during the first 5 years of life. The fracture does not until for a long time. There is constant instability and progress of deformity after formation of the pseudarthrosis. The main aim of treatment is to increase bone volume in the area of pseudarthrosis. Replace depends on it. The important problem is to determine the age of patients to begin treating. There are different opinions of experts. Methods of treatment. Bone grafting alone, intermedullary fixation, illizarov method, free vascularizated fibular grafting, amputation, electrical stimulation. Nothing approach is not ideal. Anderson shows following result. Research of Gracheva and Blaus. Recommendation for autograft. Recommendation for intermedullary fixation. Surgical technique of vascularizated fibular graft. Advantages and disadvantages. Amputation is poor treatment option. Electrical stimulation is questionable treatment. The complex of treatment includes use of bone morphogenetic protein biphosphonate zoledronic acid. We introduce and recommend illizarov method. Deformity correction and shortening compensation are not possible with common methods. Illizarov Center has experience in the treatment of more than 200 patients with congenital pseudoarthrosis. Patients have been operated on several times before. Distributions of patients depending on the type of previous surgeries. Basic technologies of transosseous osteosynthesis are closed and open adaptation of the docking site. We have the following results of treatment. Clinical example: patient with diagnosis neurofibromatosis type 1, congenital failed joint of both tibial bones. Open adaptation of the docking site. Bone volume increased by bone plastics material. The treatment result. The scheme of the lengthening with overlap of bone fragment ends. Patients with congenital pseudoarthrosis of the right tibia. The fragment lengthening with open adaptation of the docking site. During treatment and after the second stage. The other patients before treatment. The lengthening with overlap of bone fragment ends, close adaptation of the docking site, compression back to site. 1 year and follow-up. Patient with congenital pseudoarthrosis on the left tibia. The lengthening with overlap of bone fragment ends, close adaptation of the docking site. Back to site compression, the wide spines have formed like a leaf. The treatment result. The scheme of the lengthening with overlap of bone fragment ends and osteotomy. Increase of bone volume. Patients with congenital pseudoarthrosis of the left tibia. The lengthening with overlap of bone fragment ends. Elongation 8 centimeters. Osteotomy of bone fragment ends. Increase of bone volume. The treatment result. The scheme of the bone fragment lengthening with open adaptation of the docking site. This type is called Russian lock. Clinical example. The stage of treatment. The adaptation by Russian lock type. The other patients before treatment. Bone fragment lengthening with intermedially wise covered with hydroxyapatite. X-ray during treatment and after fixation removal. The scheme of the increased bone volume with displaced bone fragments. A 4-year-old patient with congenital pseudoarthrosis of the right tibia associated with neurofibromatosis type 1. Transport of bone fragment. After fixation removal. Patient with congenital pseudoarthrosis of both tibial bones with 4 cm shortening. The bone volume is increased with bone fragment. The lengthening segment. Short-term and long-term follow-up. The scheme of the open adaptation in the docking site. Multi-level lengthening of the tibial fragment. The clinical example of patient with congenital pseudoarthrosis of the right tibia. X-ray during treatment. The fragment is lengthening by 7 centimeters. 7 months follow-up. 9 years follow-up. The patient with congenital face joint associated with neurofibromatosis type 1. The open adaptation of the ends of fragment. Intermediary nail and is intermediary wise covered with hydroxyapatite, were implanted in the resection zone. The fragment lengthening 8 by 9 centimeters. 5 years follow-up. Treatment by Illizarov method is staged. On this clinical example, you can see one patient, one technology, one clinic Illizarov center, and different stage of treatment, and it might be different doctors. The boy began treating in age of 6 years. He is young man. He is 42 years old. Correction deformity of the tibia bone, the open adaptation of the fragment ends, multi-level lengthening of the tibial bones, arthrodesis of the foot joint. Conclusion, the Illizarov method is highly effective in treatment of patients with congenital pseudoarthrosis. Thank you for your attention.
Yes, I invite Dr. Agarwal to talk on congenital pseudoarthrosis of tibia, and then with the 2 papers going on, we will take the question and answer.
Thank you, Mr. Chairman. Actually, for working so many years, but 15-20 years, operating pseudoarthrosis tibia, opening, bone grafting that, and 20 to 30% has got failure union. So we have done the CT angiography in all these cases, and this is no. So, etiology is not known. Definite association with the neurofibromatosis. There are many theories. You know, everybody knows the classification, everything that is told very nicely. Now, what are the associated problems of the CPT? Limb leg discrepancy, proximal migration of the fibula, ankle mortis valgus, foot and ankle contracture, multi-level, multidirectional tibial deformity. What is the management? Achieve and maintain bone and joint alignment, achieve and maintain effective osteogenesis of the long bone, promote and enhance normal longitudinal growth. CPT treatment is a surgeon's dilemma. Treatment of CPT at present: internal fixation, bone grafting, IM rod, external fixator illizarov, free vascularized fibular graft, lateral limb malignancy, electrical stimulation, amputation. In the external fixation, compression of the pseudoarthrosis alone, compression with metaphyseal diphyseal lengthening, resection of the pseudoarthrosis side with compression by gradual lengthening, resection of the pseudoarthrosis area with acute compression followed by metaphyseal lengthening. We have developed a new approach. I have studied many, and then we have done the CT myelography angiography. Then we have find out there is a mainly problem is there is a lack of vascularity. So we thought not to open the non-union site. It further deteriorates our vascularity. So our theory is that non-union site is not exposed. We don't open the non-union site at all. No excision of the non-union site. We do 2 oblique percutaneous double osteotomy, proximal and distal to pseudoarthrosis. This we have developed after doing a CT angiography a lot. So we developed this too. And union is made between 2 new presses because we find out there was a vascularity. So these fragments can't unite. 20 to 30% were non-union. So we make union in between 2 new surfaces. Cortotomy is done at the metaphyseal region of tibia for lengthening. For example, it was a boy who had operated somewhere, bone grafting, compression was done, but the bone has not united. So what we have done, this was our non-union side. So what we have done a corticotomy over here, an oblique proximal osteotomy over here. So gradually we bring down this fragment downward. When it has reached here, we have done another osteotomy and we made the union in between the 2 new fragments. You can see that by that way we have done another osteotomy and we made the, but our surprise to know when we were doing the distraction and when we were making the distraction transportation, we got exuberant callus formation here. So this hole made a simple piece with the exuberant callus formation. That we were not knowing, we got it. This is it. So it was a boy who has got the pseudoarthrosis. It was his X-ray was there. It was non-union, pseudoarthrosis tibia. Very simple, 3 rings were there. Simple procedure. So you see that we have done one corticotomy here, one proximal osteotomy there, and gradually we brought this fragment downward. Okay. Now what happens? As soon as we brought this fragment downward, due to distraction osteogenesis, lot of exuberant callus took place and the bone has united. We have not opened the non-union site. That is the advantage of this technique there. You can see that this is the boy, final X-ray of the boy with exuberant callus formation. So this is another boy who got operated here. Plate was fixed there, it was failed there. So we applied the same frame there. So if we make the planning like this, we have done the corticotomy over here, we have put the wires over here, we have done the oblique osteotomy here. Gradually this fragment came down, we have applied the olive wire so we can displace it. So it came here so that this fragment united with this without opening this fragment. So it was X-ray here, this fragment was coming down and downward. You can see this when this fragment was coming here, so exuberant callus took place here and the bone has united with all these fragments extra and they all have united that. This is another boy who was having the pseudoarthrosis tibia here. So in the same manner we have applied the frames there. In the same manner we have done our planning there. We put one olive wire over here, one olive wire over here, one olive wire here. We have done the osteotomy here so that this fragment is coming downward and downward. This was a plan here. We bring this fragment downward. And you will surprised to know when we were bringing this fragment downward, exuberant callus took place and you can see the whole bone has united. Without, we do not open at all to the non-union side. Only thing is when we bring downward vascularity increased, that causes the. So there we have another approach in which the meducapillary opened by longitudinal osteotomy, extending from proximal pigment to distal pigment through pseudoarthrosis side. So the new blood vessels grow inside the operative medullary cavity across the pseudoarthrosis side. Thus osteogenesis occur at the pseudoarthrosis site. This was the case of non-union. We have done a longitudinal osteotomy. So vessels, new vessels took place. We have done the compression over here. And the good amount of callus took place. A boy at 2 years who was having this site there. It was a case of non-union. So we have done the longitudinal osteotomy. This was a frame application. And the bone was united nicely. So advantage of this RAM technique is non-union is made between two new surfaces, so there is no chance of non-union. Lot of adjuvant callus is formed, so there is no chance of refracture. Lift indifferency is also corrected. Associated deformities are also corrected simultaneously. Osteoporosis is not a problem, very small bone can be fixed that. Total series 15, treated by the limited 5, average union time 6 to 7 months, average follow-up 3 years. Pin-tact infection, pain, poor patient does not alter the natural history of the. So we think congenital pseudoarthrosis is no more a problem now. If treated with RAM technique, our new technique, there is no chance of non-union and fracture due to adjuvant callus formation. Thank you very much.
Thank you very much, Dr. Agrawal. Any questions for Dr. Agrawal and Dr. Timothy?
Sir, this is a question for both of you. It is a disease of tibia and tibia and fibula both. Is there any role of intact fibula in this case, or fibula is also means it also goes in non-union?
Fibula is not a problem in this cerebral congenital pseudoarthrosis. Okay, this is the basically tibia disease. And basically we have studied a lot. There is a lack of vascularity. If you increase the vascularity, the bone will unite.
Sir, in your case, you are just bypassing the.
Yeah, because we have studied by the CT angiography, when you further open the, when in one of the cases in which we have done the bone grafting, transportation, when the bone has not united. So we have studied what was the problem. So then we CT angiography will find out there is lack of vascularity. If you open it, you further decrease the vascularity. Lot of orthosurgeons must be feeling in the congenital pseudoarthrosis tibia, they operate. Even then the bone, you do the bone grafting, transportation, even the bone does not unite. Why? There is a lack of vascularity. If you increase the vascularity, the bone will unite.
So
that's our thing.
In your technique, you are just bypassing the.
Bypassing, and make the union in between two new surfaces.
But can you remove that portion or not?
We don't remove it. The whole thing, if you see this, I'm showing you. You come there, see this. Yeah, you see this boy? We were, as soon as you were bringing that, lot of exuberant callus here took place. We never accepted it. We were never thinking that. So what happens? When we were distracting, we thought we will make the another osteotomy to make the union. But to our surprise, we came to know that lot of callus took place. So osteotomy we have done only to correct the angulation. But the non-union site has union, and you can see that how much big callus is formed there. So there is no, it's a photograph taken out of it.
Thank you very much. There are no more questions. So we go to the next paper.
Neglected clubfoot. Come.
Cubitus varus.
Cubitus varus. Modified osteotomy. When you do the osteotomy and when we correct the deformity, it usually rotates it. So the fragment used to be displaced. And second thing, the problem was when you used to fix it, it was very difficult to fix. But and whatever deformity you have corrected, sometimes it happens that the deformity is not fully corrected. So we have developed this technique. Cuptus varus is the most common complication of the supracondylar fracture in the children. Correction is by osteotomy and stabilization. Various stabilization procedures are in use now with their limitations. Fixation method range from simple K-wire to plate and screw. Claim of good results in almost all fixation type in literature, but complications and functional outcome may vary. What then is the dissatisfaction? Extensive exposure, incomplete correction, fixed method, prolonged immobilization, cosmetically unacceptable scars, neurological complications. Illizarov techniques intend to overcome all these. What is the aim? To achieve a less invasive approach to correct the deformity in all planes through gradual distraction, translation and derotation to reduce complication rate a minimum. We have operated 12 patients, 5 male and 7 females. Duration about the 5 to 9 years. Mean varus angle was 18 degree. Mean time to union was 13.6 months. What is the pre-operative point? First of all, we do the pre-operative. We take the long X-ray, planes of deformity, functional limitation, neurological complication, and here we make our angle, how much we have to correct. Now we are always make a pre-operative frame there. We put the 2 hinges over here, this and this. Because we operate, usually the deformity cora is at the just above the olecranon fossa, and we do osteotomy of the upward. So we put this like a juxtaarticular frames. And what is that? The distal wire, the reference wire is inserted from the posterolateral aspect of the lateral condyle. Mind you, we go from the lateral condyle towards the anterior surface of the medial epicondyle, 6 to 8 degree vulgus. Whatever angle was deformity was there, so we go to more 6 to 8 degree. Wire is fixed to the preconstrictor plate with juxta-articular hinges. A proximal wire is inserted from the anteromedial direction to image the posterolateral. The second distal wire is inserted from the posteromedial aspect of the medial epicondyle to the anterior cortex of the lateral condyle. A half pin is inserted in the posterolateral surface of the lateral condyle. A third wire is inserted as a proximal link, 10 to 15 degree of inclination. Subperiosteal, mind you, we do not open at all. Subperiosteal automatically done at the predetermined size, apex of deformity and drill holes to prevent shattering of the distal fragment. Active and passive exercise are commenced as soon as pain subsides. Gradual correction done post-operatively. Hinges adjusted and all are tightened to the frame after full correction. Frame removed after healing. The difference in carrying angle of the corrected elbow whereas contralateral elbow is more than 5 degree. Our results are that excellent, good and poor. Average carrying angle at the completion of the treatment of 5 degree. 2 patients have limitation of flexion. 1 patient had carrying angle of 12 degree with also limitation of the 20 degree. So result poor in 8.3%, good in 16%, 9%, 70%. This was a young boy who was having the varus deformity. So here is the varus deformity, 38 degree was the varus. So we applied in the same manner the hinges there. We always apply the pulling